Okay, this is, I know this is in the stroke section, but I'm going to go over the first of many lysosomal storage disorders that I'm going to discuss over the series of the next year. And the first one I want to talk about is Fabry disease. So first I want to talk about lysosomes, and I know biochemistry has talked a little bit about lysosomes, but lysosomes are intercellular organelles. And their job is, our cells are very green. If only we were as green as our cells, but our cells are very green. And whenever we're done with something, whether it be carbohydrates, nucleic acids, lipids, we get rid of that. We send them to the lysosomes, we break them down into small components, and we excrete them out of the cell that's picked up by the blood and excreted. Each enzyme reduces a particular macromolecule to a smaller component, and these smaller pieces can then be eliminated from the body. The problem arises in lysosomal storage disorders when one of these enzymes to one of these many pathways is not functioning, and as a result, that substance gets into the lysosomes, but it can't get out. So the lysosomes get larger and larger and larger and really kind of take over the cell. This is kind of an overview of a lot of different lysosomal storage diseases, and I will show you this in various lectures. But bottom line, ceramide trihexide goes to glucocerebroside. In Tay-Sachs, it's a ganglioside going to glucocerebroside. In Niemann-Pick, it's sphingomyelin going to ceramide. In galactocerebrosidase to ceramide, and you can see glucocerebroside is one of the main components here, and ceramide is even greater. So all these enzymes in all these, here we have Tay-Sachs, here is some called metachromatic, Krabbe's disease, Niemann-Pick, Gaucher's, Fabry's, are all involved in breaking down large chemicals to a more common denominator here. So let's talk about Fabry disease. Our cells, as I said, are very efficient. So whenever we want to get rid of something, we send it to the lysosome. And in the case of Fabry disease, it's something called GL3, which is a glycolipid. And it goes to the lysosomes to get broken up by this enzyme alpha-galactosidase A. And life is good. And it's all metabolized, so everything's great. However, the problem in Fabry disease is the enzyme GLA is not functioning correctly. So this GL3 gets into the lysosomes, but it can't get out. So it gets bigger and bigger and bigger, and the lysosomes overtake the cell. And this large cell then impinges upon small capillaries. And some of the smallest capillaries that we have in the body are in the kidney, the heart, and the brain. And so it obstructs small capillaries, and this results in ischemia to cells and cell death, and a lot of other things which we're going to talk about. So let's look at a typical family history. We look at a family history, and mom is 40. Mom had an MI at 46, and she's now 47. She had a sister who had a stroke at 44, and she's now 53. And another sister who died of a stroke at 42. A sister had a stroke at 42 and died of an MI at 45. So it's like, wow, this is like not normal. And the maternal grandmother died of an MI at 56, and her brother died at renal failure at 39. But this is the kind of family history that you see in Fabry disease, that there's strokes, heart attacks, and then in males, kidney disease. Males usually start showing signs of Fabry disease in early adolescence, and early symptoms include the inability to sweat, because the sweat glands also have very small capillaries that become obstructed, and often even during childhood they don't want to be outside, their face turns red. Acroparesthesia is this pain in the hands and feet, and this non-blanching skin rash. The other thing is a whorl keratopathy in the eyes. Renal failure, stroke, and cardiovascular disease is one of the main causes of mortality and morbidity in both males and females. And so you might notice I did not put X-linked recessive because females can have symptoms as severe as males, and the gene involved in Fabry disease, its non-functioning, is located on the X chromosome. It's called alpha-galactosidase A, or GLA. If a female has one normal copy and one non-functional copy of GLA, her sons, if they get the non-functional copy, they will have male Fabry disease. If they get the normal copy, they'll be fine. If she gives her daughter the normal copy and dad gives his normal X, a female will be fine. And if she gives the non-functional copy and dad gives a good one, this is a female. And I don't like to use the word carrier because females can have as severe symptoms as males. So as I was saying, the deficiency of this alpha-galactosidase A results in deposition of this big chemical called globotransceramide. Again, it's a glycolipid in the vascular endothelium. It obstructs these small capillaries. And this results in narrowing of the vessels and ischemia, as I showed you in the earlier slide. And the smallest capillaries are in the kidney, heart, and the brain, and this is why we have so many symptoms early. Cardiac complications. This is one of the most common complications, and what we get is left ventricular hypertrophy, mitral valve prolapse, and regurgitation. Cerebrovascular, and this is what we're really going to be talking about today. I know you did cardiomyopathy already. We actually have this gene on the cardiomyopathy panel because it's one of the few causes of cardiomyopathy that's actually treatable. But it also causes cerebrovascular disease because of these small vessels. Symptoms can range from a transient ischemic attack, basal arterial ischemia, and cerebral hemorrhage or stroke. And so here you can see all these little evidence of small ischemic events and the narrowing of over here of these small vessels. So let's look a little as the GL3 accumulates as the individual ages. The early symptoms can be, as we're starting to get some damage, could be migraines and blood vessel abnormalities, followed by MRI abnormalities and transient ischemic attacks. So transient means it gets better, and then it doesn't get better. We have cerebral hemorrhage, we can have dementia, and then full-blown stroke. So the longer this accumulates, the more it accumulates in the brain, and so it's a progressive thing. Women in Fabry, I told you there's 2 copies of this gene. I mean, the gene is located on the X chromosome, and females have 2 copies. And we've really gotten away from the whole concept of X-linked because females are really a mosaic. Yes, they have 2 copies of the gene, but it's not like autosomes that both are functional in all the cells, except for imprinted genes. But anyway, but in the X chromosome, either the X is on or it's off. And so if the X that has the non-functional copy of this alpha-galactosidase A is the one that's off, the one that's on, the non-functional is on the X that's on, then you don't have any functional enzyme in that small pocket of cells. So let's say in the brain, there's a small pocket of cells that is not making the the alpha-galactosidase A. Well, we have obstruction, we have accumulation of GL3 in those small pocket of cells and obstruction of small capillaries. And what is that called? A stroke. In the heart, we have accumulation of the GL3, obstruction of small capillaries, and obstruction of, coronary vessels, and that's a heart attack. And also the damage can result in what we call cardiomyopathy. Hypertrophic cardiomyopathy is actually very common in females. The other kidneys, the truth is you only need 1/4 of one kidney to have normal kidney function. So females can have a little bit of damage on one kidney, a little bit of damage on the other kidney, but they usually have normal kidney function. If you do very specific tests, we do like urine looking for microalbumin, things like that, you can see that there is some damage to the kidney, but it's usually subtle. But this female would not be a good candidate to be, for instance, a kidney donor to her brother or cousin or somebody else in the family that has Fabry because she needs both of her kidneys. The other thing is world keratopathy, and this is an ophthalmologic feature. kind of this whirling pattern. This actually is seen more in males and females and males. It doesn't affect vision, but it can be a sign that the ophthalmologist sees to determine that they might have Fabry disease. So again, the main problem in Fabry is a microvascular disease and the accumulation of this GL3 or lysosomal byproducts in the cell. It includes the microvasculature of the kidney, heart, and the brain. Occlusion results in death of tissues by ischemia, and progressive neurologic disease is common complication, including stroke and dementia, although cardiovascular is actually the most common cause of death. But stroke is a significant risk. So management, for the enzyme deficiency, we can actually give enzyme through the IV. The problem with that is it's really good for the kidney and the heart problems, but this enzyme does not cross the blood-brain barrier, so it's not quite as good for the decreased stroke risk. Substrate reducer, if we can't make the enzyme, let's not need it as much by blocking the first step of the synthesis of the the glycolipid. Cardiovascular, you're at risk of heart attacks and things like that. So you want to have annual echocardiogram looking for evidence of cardiomyopathy, annual EKG looking for arrhythmias, monitor for hypertension, renal, annual blood, urine studies, monitor for renal disease, pain, gabapentin. With regards to the stroke, know that they're at risk. Sometimes people do MRIs. It's not necessarily going to change anything. But if there's any evidence of a TIA, need to actually get an MRI or MRA just to see what's going on. So in conclusion, Fabry disease is a lysosomal disorder which can result in premature stroke. And while it's, treatment, while it doesn't get past the blood-brain barrier, it can decrease the amount of the GL3 byproduct, so it may help to some extent. But as I said, unfortunately, the current therapies that we have don't cross the blood-brain barrier, but future ones will. And that concludes this.